Hello everyone, my name is Meredith Pence. I'm a student at St. Joseph's College of Maine, and today I'll be talking about gastroesophageal reflux disease, better known as GERD. GERD is a common health condition that occurs when gastric contents repeatedly flow back into the esophagus, causing discomfort and other symptoms. Because gastric contents are highly acidic, over time this disease can cause breakdown of the mucosal barrier, leading to esophageal stricture, Barrett's esophagus, and increases the risk for esophageal cancer. GERD is a common condition with about 1 in 5 people requiring medical treatment for it. However, this number is likely severely underreported given the ability to use over-the-counter medications for mild symptoms. The most likely cause of GERD is the inappropriate relaxation of the lower esophageal sphincter pressure. Normal LES pressure ranges from 10 to 30 millimeters mercury, and in GERD is typically less than 10. Irritating foods such as chocolate, onions, and peppermint, medications, smoking, alcohol consumption, obesity, and poor lifestyle choices all increase the risk of developing GERD, as they either reduce LES pressure or irritate gastric mucosa, causing reflux. For example, in one systematic review, researchers found that the likelihood of developing GERD is 23% higher in a smoker compared to non-smokers due to how nicotine reduces the LES pressure, along with other irritating factors with inhaling smoke. Additionally, another risk factor that may be surprising to some is how depression and anxiety may contribute to development of acid reflux. In a systematic review, researchers note that the risk of GERD was almost 50% more likely in those who scored positive for depression compared to those who did not. Again, this has to do with the body's mechanism of anxiety, in which, along with many other changes, causes relaxation of the LES. For the pathophysiology, in the normal body, the LES closes after passage of food contents and does not allow reflux back into the esophagus. And the crural diaphragm assists in regulating LES pressure so that when physiological activities occur, the pressure gradient remains stable. When there is a poor coordination between the LES and crural diaphragm from factors such as diet or medications, insufficient pressure occurs and gastric contents begin to reflux back into the esophagus. Another way reflux can occur is when there are transient LES relaxations, often followed after eating a meal. It is triggered by a vaguely mediated reflex that detects gastric distension and stimulates the LES to a temporary relaxation. This causes venting of gastric gas, followed by reflux. Transient LES relaxations are actually the most common cause of reflux in healthy adults. Thoracoabdominal pressure gradient is another way GERD can occur. Typically, pressure can be regulated by the LES and crural diaphragm, but when the thoracoabdominal pressure is elevated, typically by pregnancy, obesity, chronic respiratory diseases, or ascites, it overcomes the anti-reflux mechanisms causing GERD. Hiatal hernia disrupts the normal position of the diaphragm, causing the LES to be displaced into the thorax. The hernia prolongs the exposure of gastric contents in the esophagus and can also produce a buildup of pressure, increasing the likelihood of reflux. When gastric acid reflux occurs, this causes an inflammatory response. Through repeated exposure of gastric acid, the esophagus struggles to move the contents as quickly as it once did, which prolongs the exposure to the acid. Eventually, erosion occurs and the normal squamous epithelium is replaced by metaplastic columnar epithelium. Although this new epithelium is more resistant to acid, it is a premalignant tissue which increases the risk of esophageal cancer. Symptoms range from mild to severe and include heartburn and regurgitation of stomach contents. Other atypical symptoms include dysphagia, sour taste in the mouth in the morning, globus sensation, belching, water brash, wheezing at night, autophagia, hoarseness, chest pain, and chronic cough. Aggravating factors that make these symptoms worse include reclining or laying down after eating a large meal, triggering foods such as spicy foods, caffeine, or fatty foods, constrictive clothing, heavy lifting, or straining. The physical exam is done in the PCP office is typically nonspecific, and therefore diagnosis is often based on subjective findings. However, there may be a palpable hiatal hernia present, or upon a rectal exam there may be positive occult blood. 3 differential diagnoses to rule out include peptic ulcer disease, gallbladder disease, and angina pectoris. Peptic ulcer disease is when there is a break in the gastric or duodenal mucosa causing an ulcer. Symptoms of PUD are often similar to Gerd, however, can be differentiated by the fact that in PUD, heartburn is often relieved by eating, whereas in Gerd, symptoms usually worsen after eating. H. pylori testing may be indicated to rule out PUD if caused by a H. pylori infection. Gallbladder disease is typically associated with nausea, vomiting, increased pain after a high-fat meal, and a positive Murphy sign. Gerd typically does not present with these symptoms, therefore one can be ruled out depending on patient presentation. Because Gerd can present with chest pain, angina pectoris, or other cardiac events are a do not miss diagnosis and require further testing. Pain that is associated with exercise and relieved by rest or cardiac medication indicates that the chest pain is cardiac in origin. An EKG is helpful in ruling out an acute cardiac event. For labs and diagnostic testing, diagnosis is often based on physical exam, patient history, and reported symptoms. Therefore, there is no gold standard diagnostic use. For patients with typical symptoms of GERD, such as heartburn and regurgitation, they will be started on a proton pump inhibitor as a diagnostic test and treatment. If the patient responds to the PPI, then it is reasonable to believe that they have GERD. Any patients with atypical symptoms, such as voice changes, chronic cough, or glottis sensation, should be referred for a prompt upper endoscopy. Additionally, in patients with typical symptoms that have a partial or no response to PPI therapy should receive an upper endoscopy. Reflux monitoring aids in diagnosis by monitoring acid exposure and can be done by either a wireless telemetry capsule placed during the endoscopy or a transnasal catheter. This test looks at the number of reflux events and reported symptoms, calculates a mathematical equation, and a score of 95% or higher is considered positive for GERD. For patients considering surgical intervention, reflux monitoring is required if there is no sufficient evidence of erosive esophagitis. Esophageal manometry assesses motility abnormalities that may be present in GERD by evaluating esophageal tone and coordination, but it is not a diagnostic of GERD by itself. Additionally, as stated earlier, the EKG and H. pylori testing, such as the urea breath test, may be included to rule out other diseases. For the plan of care, the goal of treatment for GERD is to eliminate symptoms and reduce risk of long-term complications. For patients with classic symptoms, an 8-week trial of PPIs are indicated. PPIs work by inhibiting gastric acid secretion, thus reducing the amount of gastric acid that could be refluxed back into the esophagus. It is recommended to start with 1 dose daily in the morning prior to a meal, but may be changed to a different time, such as taking at night if symptoms are most prominent at night. A different dose, such as changing from a daily dosing to twice a day in the morning and in the evening prior to meals, or switch to a different PPI. If after this the symptoms are still present, the patient should have an endoscopy done. If red flag symptoms such as dysphagia are present, the priority is to have an endoscopy done as soon as possible. For these patients with recurrent symptoms after a trial of discontinuing PPIs, they will likely need long-term maintenance therapy of a PPI for symptom reduction. Second-line medications include antihistamines and baclofen. Antihistamines taken at bedtime may be beneficial as a conjunctive therapy with PPIs for patients who have severe nocturnal symptoms. Baclofen for GERD works by reducing the frequency of LES relaxation, but have limited studies on effectiveness of symptom management at this time. After all treatment options and all other causes have been ruled out, the patient may be a candidate for surgical intervention. The most common surgical intervention for GERD is the Nissen fundoplication, which is when the top of the stomach is wrapped around the bottom of the esophagus to reinforce the LES, prohibiting reflux from occurring. This is a visual representation of the American College of Gastroenterology's recommendations, which is starting with that 8-week trial before meals with the PPI, and then depending on if there's relief or not, to continue either with the PPI or go through an endoscopy. For non-pharmacological plan of care, patient education is imperative for symptom relief. This includes weight loss, avoid eating meals within 2 to 3 hours of bedtime, smoking and alcohol cessation, avoid trigger foods, elevate head of bed while sleeping, remain sitting upright after meals, avoid tight or restrictive clothing, and changes in diet. Low-carb diets are consistent with lower scores on patient-reported symptom scales. There's been studies on the Mediterranean diet and GERD have indicated a decrease in GERD-like symptoms. In one study, patients who were not adherent to a Mediterranean diet were actually more than twice as likely to report reflux symptoms. This is where the link to this presentation video will be. And here are my references. Thank you so much for watching my video.